Now, one of the things that you might need to consider with a patient with patellofemoral pain is whether or not they've got patellofemoral osteoarthritis. We used to think that these were two very distinct conditions and that PFOA really only occurred later in life, much like tibiofemoral OA. But what we've started to notice through our research and through others' research is that that's not always the case. And we can see people as early as their late 20s are showing structural signs or imaging features of patellofemoral osteoarthritis. Now, what makes it quite both interesting and confusing from a diagnostic perspective is that the characteristic signs and symptoms of the two conditions are actually very similar. So your patient with patellofemoral OA is likely to report things like pain around the front of the knee, so either around or behind the patella, that's related to activities that involve patellofemoral joint loading, so weight-bearing knee flexion activities. They are likely to have some sort of crepitus, so that also can overlap with patellofemoral pain. And like I said, we used to think that age might be a way that we could distinguish between the two, that older people would be likely to have PFOA and younger people would be likely to have PFP. But age is not something that we can really use as a diagnostic criteria anymore. One thing that you might find different between people with PFP and PFOA is reports of stiffness. So someone with patellofemoral osteoarthritis, like with any other osteoarthritic condition, might report feeling stiffness in the knee, particularly first thing in the morning or after they've been sitting for a while. Generally, that should be easing within about 30 minutes though. Any stiffness that's lasting longer than 30 minutes, we're starting to think that there might be more of an inflammatory or systemic type arthritis present. So what we would ask Josh or ask our patient is whether they do experience any stiffness, particularly if we're starting to think that there is an OA component to their pain. We would put that with all of our information, and then we need to think about what we might do with that. So is it going to change our management? Are we going to refer for imaging if we think that's important for our patient? Most of the time, not. So we would just continue, or we would treat PFOA very much in the way that we treat patellofemoral pain. If things aren't progressing, then, or the patient specifically requests it, then we could consider referring for imaging if that's warranted. But we do need to be careful around imaging and making sure that we choose patients who we think are actually going to benefit from that information. So for some people, knowing that they've got some structural features of OA in their patellofemoral joint might be the motivation that they need to actually manage their knee pain well, to look after the long-term health of their knee. But for some people, if they have an X-ray or an MRI and they see that there are structural features of OA there, that can actually start to feed into that whole pain catastrophizing, damage, fear avoidance belief cycle. And so just be very mindful if you're thinking that you're going to maybe refer for imaging, that you really consider the individual in front of you and whether that will be most appropriate for them.